It's just we're live.
Okay, so we are live. So a warm welcome to members of the public, both here and online. To those here, just a very polite reminder that this is a meeting which is held in public, not a public meeting, but you're most welcome to listen to our deliberations. May we start with a round of introductions, please? I'm Mike Thorne, the chair of the Mid and South Essex Integrated Care Board.
Good afternoon, everybody. I'm Giles Thorpe. I'm Executive Chief Nursing Officer for the Integrated Care Board.
Good afternoon, Jo Cripps, Executive Director of System Recovery for the ICB.
Good afternoon, everyone. Joe Fielder, non-executive member of the ICB.
Good afternoon, I'm Neha Sabran, a non-executive member of the ICB.
Good afternoon, I'm George Wood, a non-executive member of the ICB.
Hello, Shahina Pardan, Associate Non-Executive Member for the ICB.
Hello, Jeffrey Hussain, Associate Non-Executive Member of the ICB.
I'm Mark Bailey, Associate Non-Executive Member of the ICB.
Good afternoon, I'm Rob Percy, Interim Executive Director of Adults and Health and Therapy Management.
Yeah. Thank you. Lucy Whiteman, Chief Executive of Provide Health and Group Chief Nurse.
Hi, good afternoon. I'm Mark Harvey, Executive Director for Adults and Communities at Southend City Council.
Hi everyone, I'm Peter Fairley. I'm Director for Strategy, Planning and Assurance at Adult Social Care at Essex County Council.
Good afternoon, I'm Anna Davey. I'm the Primary Care Partner Member.
Good afternoon, Alex McCann, Alliance Director for Thorough and Executive Mental Health.
Pam Green, Alliance Director for Basildon and Brentwood and Exec for Primary Care.
Good afternoon, Becky Jarvis, Alliance Director for South East Essex.
Hello, I'm Claire Hankey. I'm the Director of Communications and Partnerships for the ICB.
Afternoon, Matt Sweetin, Executive Medical Director for the ICB.
Afternoon all, Jen Kearton, I am the ICB Chief Finance Officer.
And Kathy, perfect timing just to introduce yourself, and we know you've been busy.
I'm Kathy Bonney, I'm the Interim Chief People Officer. Sorry, bit out of breath.
Okay, well, welcome everyone. Peter, this is your last meeting. We will miss you. Thank you for every bit of support you've given this board and indeed me personally in this role. It's been much appreciated. We will miss you. Today, of course, there's lots of stuff and news in the press. It's been a very busy day as far as our government is concerned. The government is doing what governments do, which is change things in the way that they believe will make things better. One of the consequences of that is we don't have our Chief Executive, Tom Abel, with us. He's at a meeting in London where some of these changes are being discussed pretty much as we speak, and Giles is standing in for Tom. So when we get to the Chief Executive's report, Giles might just touch, as well as on items in the report, on some of those changes that particularly affect us in the Mid and South Essex Integrated Care Board. But we have work to do, and we're now going to get on with it. We've got an update on the Register of Interests, and I don't think there's anything special arising from the papers in this part of the meeting. We have some questions from the public. Peter Blackman has asked a question which is requesting summaries of records of meetings held with various groups regarding the community services consultation, so that those who are not members of working groups can follow the process. There's a response from our Chief Executive, which Giles will now read.
Thank you, Chair. So thank you, Peter, for the question. And this response has been sent to you via email. It was agreed by the working group that the detail of meetings would not be circulated broadly so as not to prejudice the discussions of the working group, given that these are dynamic in nature. The focus in respect of St Peter's has very much been on the future location of ambulatory care services and exploring the underpinning rationale around changes to IMC, intermediate care, and stroke beds, and midwifery-led birthing services at St Peter's. A more detailed update on the work of the working group was included within the January board papers, which included the 3-month report of the working group. Any wider discussions around integrated neighbourhood team development happen with those groups and are not within the scope of the community consultation working group.
Thank you. There's a question from Jackie Foston, who says, want to ask about GPs refusing to issue ADHD prescriptions as part of a shared care agreement. It says here, due to ongoing insufficient support resource funding from the ICB. And Pam, I think you're going to read the response to that. There's a similar related question from Paula Farrow, saying that several families have approached Paula's charity concerned about being able to obtain medication for their privately diagnosed children with ADHD and asking for confirmation of communication processes, waiting times, and how to obtain medication. Pam?
Thank you, Mr. Chairman, and thank you to Jackie and to Paula for their questions. I believe Jackie has received a telephone call from one of my team, and this is the covering statement for both questions. The ICB has made an offer to GPs to receive additional funding to continue to prescribe and monitor ADHD medications on a per patient basis. Several GPs have signed up to this agreement, and ICB holds a list regularly updated with GP practices who have opted in and out of the arrangements offered. Where a number of practices have opted out, children's registered with the practice are being referred back to their specialist provider, those whose care they are under for ADHD. Patients who have privately funded their treatment will be referred back to their private provider or into an NHS funded service following discussion with their GP. GPs have been communicating directly with their patients, advising how to obtain medication and more detailed guidance and frequently asked questions regarding ADHD medication, including steps to address the concerns being raised, have been posted on the ICB website. We are unable to advise regarding waiting times as they will be varied across the location and provider delivering the services.
Thank you. So we now come to the approval of the minutes of the previous meeting. Anyone got any issues with those? As usual, silence, or you haven't let me know in advance, is 100% agreement. Thank you. Matters arising, I think there is certainly one, Jen.
Thank you, Chairman. The board will remember when we met last time, we received a paper and agreed the award of some contracts to our NHS providers for the coming 1 year, in some cases 1 year, some cases 3 years. We will note that that morning we were asked to include the specialist commissioning, for which we now have delegation, into the Mid and South Essex Foundation Trust contract. That was not timely enough to make the board papers. However, we have made that change as requested, and I can confirm to the board that the new value of the contract for the Mid and South Essex Foundation Trust for the next 3 years will be 4.01 billion. And that has been confirmed, and that is with the inclusion of 700 million worth of specialist commissioning activities.
And everything else is constant.
Everything else is unchanged.
Okay, happy with that. Thank you very much indeed. Any other matters arising? There's lots of things we're following up on the agenda. Thank you. There's the review of the action log. There are 2 actions, both of which are due at our next meeting in May, our next formal meeting. So we'll look forward to those coming through then, which brings us on to our first substantive item, which is the joint forward plan, which is a statutory requirement that we update this each year and approve it. Jo.
Thanks, Mike. So I'll take the papers as read. This is, as you say, a statutory requirement for integrated care boards to have a joint forward plan that describes the forward plan for the next 5 years and is updated on an annual basis. This is the 3rd year of our joint forward plan. So what you've got in front of you is 2 of 3 parts for the joint forward plan. So part 1, Appendix A in your papers, is basically a recommitment to the strategic ambitions that we agreed in the first iteration of the joint forward plan, and we agreed those with our 3 upper tier health and wellbeing boards. Once we approve this, and I've seen, as I've read through it again today, some some typos that we need to tidy up, which we will do. But once approved, this section will be published on the ICB website. Part 2 is a look back over 2024-25 and looks at some of the successes we've had as an integrated care system, and that will also be published on our website, but also form part of our annual report. So, and I think you'll agree there's a huge selection of very positive things that system colleagues have been involved with delivering. Part 3 isn't in the papers today. It's currently under development, but effectively it becomes our forward plan for the coming 5 years. So it will incorporate the 2025-26 planning guidance, the elective care reform guidance issued by NHS England. When the NHS 10-year plan is published later in the year, it will reflect the actions required in that, and will also reflect our local medium-term plan, which we've been working on with system partners. So that will, part 3 will come later. So this, the parts 1 and 2, or the process by which we're refreshing the joint forward plan will be discussed with our health and wellbeing boards in the coming weeks. We are awaiting some commentary or feedback from NHS England, but otherwise, if the board is minded to approve the joint forward plan, once we've done the editing check, that will be published on our website. Happy to answer any questions.
Thank you. So just to be clear, this is, we were set, as it were, tram lines by those people who were there to advise us, our various councils and so on, the NHS England headquarters and all the rest of it. And we're pursuing those lines. We haven't deviated from those, but this is the most recent iteration of this forward plan as best we can just now, yeah? Joe.
Thank you, Chair. I just wondered, Joe, in the context of the third part that's not yet with us, and in light of our finance and performance report later, how specific that final part of the planning documentation will be in terms of recovery of services where we're not yet comfortable with our performance as a system. Thank you.
Thanks, Joe. So I think the medium-term plan in particular aims to address those areas of clinical, financial and operational sustainability and performance where we know we are not performing as a system as well as we could be. So I'd expect the medium-term plan, as well as the particularly around elective care, because that is a kind of political priority, I'd expect that part 3 of the document, which will come later, to describe how we will recover in those areas.
Thank you. Other questions or comments? Jeffrey?
Thank you. Thank you. If I can make reference to working partnership part there, and my question really is about the visibility of just for the record and for completeness, visibility of the VCSE in the write-up. So I think under 3.2 it does make reference to a community assembly, but I'm not sure we're using community assembly anymore, or are we still using that, or is it VCSE assembly? But also being more explicit, our VCSE is part of our developing the system section there as well. So maybe just a bit more strengthening was what I'm suggesting. Thank you.
I'm happy to pick that up.
Thank you. Shahina?
Thank you, Joe. So on page 26, we talk about supporting NHS research and the fact that we're going to publish an updated research strategy. I think it'd be good to know where that would be. And also the fact that we now are part of ARC, and that needs to be included too, please.
Thanks, Sheena. We've just, executives have just agreed for a step up of our research and innovation board. And the idea behind that is obviously it's one of our statutory functions, but we want to bring together partners from across our system to have a clear strategic direction focused on delivery and our medium-term plan and real-world research. So your finger's on the pulse, it's come in and it's just been approved. So, and you'll be invited.
Other questions or comments? If not, are we happy to approve, subject to these amendments, that this goes through, which is basically the next phase, because part 3 brings in the changing circumstances around us, which are changing rapidly. I mean, I thought reading this, we still got a lot we need to get done. And we're clear, I believe, in this document about that, and we are determined that it will get done. But also, there's been an awful lot of stuff that has got done and that has moved things on in our system, and that we, I think, can be together, all the system players, rightly proud of, but recognising there is still plenty of work here to do. So thank you, Joe, for putting it together. And we've, I think, now approved that to go on. Thank you. Equality Delivery System 2022 Annual Statement. I think it's a really important document. The jargon doesn't help. Over to you, Giles.
Thank you, Chair, for that introduction. So the Equality Delivery System for board members to recognise is a requirement of both NHS commissioners and provider organisations. And there are 3 domains of which there are multiple subsections as noted in the appendices. The first relates to commissioned or provided services where a system response has been developed with both Essex Partnership University NHS Foundation Trust in relation to their diabetes service and Mid and South Essex NHS Foundation Trust in relation to their paediatrics transition service, and also the heart failure service led through the community collaborative. Whereas the domains 2 and 3 relate to the ICB's development of workforce health and wellbeing and also inclusive leadership. The overall conclusion of the work undertaken is that the system and ICB is rated as developing according to the Equality Delivery System standards, and it is the request of the board to ratify this position statement as this has been agreed by the Executive Committee on the 18th of February this year. That's all I wish to say, Chair.
Thank you, as you may wish or not. I have to say, yesterday, in terms of domains 2 and 3, back to jargon, there was a fantastic event just yesterday about women in leadership roles across our system, a superb day. Actually, I don't quite know, Matt, who put it together, but it was a very, very good day indeed.
Our very own Dr. Sarah Crane, our Deputy Medical Director, and her team actually as well. So I'm grateful.
Yeah, it's a very good day. Any questions or comments? Are we happy? I think this is reporting on work we've done and work we have to do and the self-evaluation. Those are the 3. Kathy, anything you wanted to add?
No, thank you, not at this point.
Okay. So what do we need to do formally? Ratify. So happy to ratify this document? Thank you very much. Okay, so we move on now to the Chief Executive's report. We'll come to that in a minute. But first of all, Giles is going to just rehearse a version of a statement which we've been sharing with stakeholders as a consequence of announcements which were made to us as an ICB just yesterday evening, where we're still actually working out what the consequences of these are for us and thinking about what we need to do to hold everybody together. So, Giles.
Thank you, Chair. So I want to provide this statement to update both the board and the public on some news that you may have seen today in the media and what we currently know about what will mean some significant changes to our ICB and ICBs across England. NHS England has mandated that all integrated care boards reduce their running costs by 50% as part of a broader financial and organisational reset across the NHS and the Department of Health and Social Care. This directive follows previous cost-cutting measures and will require significant changes across the entire NHS system, including our organisation. To deliver this mandate will require a fundamental shift in how we operate. Whilst we don't have much detail at this time, I anticipate we will rapidly move to working on the following areas: the need to comprehensively review of our structure to identify where cost savings can be made, as well as considering how we may work differently with others in our system or more broadly across the NHS. A focus on core functions to ensure we continue to meet our statutory responsibilities. The fact is that in order to achieve such a reduction, staffing levels will need to be assessed and role reductions will be necessary. This will no doubt result in some disruption in some of our work with our partners and stakeholders. I would like to assure you that no decisions have been made yet, and there is much to do to work through the implications of this mandate. Especially where these will have impacts on our partners and stakeholders, we will do our best to keep you informed and involved whenever that is possible. This is clearly a difficult and distressing time for our whole team at the ICB, so please bear this in mind as you are working alongside our teams. Hopefully you, like us, value enormously the energy which they have been giving to moving the health and care system along since our establishment in 2022. Further information will be through our usual channels as more details are shared with us. Thank you.
Thank you. And the situation will get more complex given the Prime Minister's announcement today that NHS England is going to be disbanded, and they are our principal sponsors. So we just have to take it day by day with the challenge of making sure that our very able and incredibly supportive colleagues continue to do the best they can for the population we're here to serve, notwithstanding the uncertainty around it all. Now we have a Chief Executive's report here. As I said, he is, I think, now on his way back from a briefing about some of these major changes that were announced to NHS colleagues this morning. So I'll have to sort of take questions and make them difficult ones because Tom's then going to answer them. Not Tom, sorry, Giles is going to answer. It'd be easy for Tom to answer them. It's Giles is going to answer, so make them especially difficult. Now, come on, who's going to be first? It's a sort of report of what Tom has been up to since we last formally met. Of course, we kept aware by him as things run along. I don't think there's anything there I particularly wanted to pull out. This is all work ongoing. For example, cancer performance, elective performance, urgent and emergency care performance, and finance, crucial issues for us to continue to work together to get a grip on. And he's kind of updating us on that. So, oh yes, George.
Excuse me. Yeah, I think building on the cancer performance, it would be really helpful to have a concise paper put together. I know that they meet with NHS England bi-weekly, but as a board, I don't get the assurance in terms of next steps, plans, how successful they're going to be, how sustainable. So I think if we can somehow be able to pull that together, it'd be really helpful, please.
Yeah, and I absolutely agree because it's such a priority and we're not where we want to be on the regional comparison table. So we have to continue our focus on that. So we'll commission that report for our next meeting. Thank you, George. Anything else? If not, I'm going to move on. So this is onto the quality report. And so Giles, this is you in your own right.
Thank you. Easier questions, I hope. Thank you, Chair. So I'm happy to take the quality report as read, which offers an update from some conversations that have been had at our quality committee and other key aspects in relation to quality across our system. Key highlights for me are, I think, a very positive deep dive that we had into dentistry services, which has noted a number of pilots which exist in our system, which has had a radical improvement in access and outcomes for our residents across Mid and South Essex, not least with the dental access pilot that has had a total of 21,732 additional patients being seen across our system. And an incredibly touching and heartwarming video of the care home pilot, in which we were provided some detail around how important it is that we have ongoing dentistry support for the most vulnerable in our society who are in our care homes, really seeing some radical differences, and for some individuals actually the opportunity to eat food for the first time in a long time. And my thanks to our partners in dentistry who have really engaged and stepped into this space. There was a further focus on babies, children and young people, which was provided to the Quality Committee. Some improvements in relation to our planning around initial health assessments for looked after children. The contract award, which has been finalised for counselling services for children and young people, which is positive to note. But of course, recognising that there remains an ongoing risk in relation to our children and young people with learning disabilities and autism and neurodivergence who are at risk of being admitted into our inpatient mental health settings, which is a key area of focus that we maintain across our system. I am pleased to note, and this is a requirement of the board to be cited, that in relation to the clinical negligence scheme for trusts, also known as the maternity incentive scheme for year 6, Mid and South Essex NHS Foundation Trust has achieved all 10 of the safety standards for this year. The information has been reviewed both within the trust and also via the National Maternity Improvement Advisors and the local Maternity and Neonatal Safety Board, and has now been signed off by both Matthew as the provider chief executive and also by Tom as the system chief executive. A fuller report outlining the safety standards and the evidence associated with those will be submitted to the May board. However, due to the timescales, it was not possible to provide the report at this time. In terms of the recommendations, it's obviously to note the development work that is underway, compliance with CNST standards, that are commissioning decisions in relation to looked after children, and also noting the ongoing risks for our children and young people with learning disabilities and autism. Thank you, Chair.
Thank you. Just to say a word on dentistry. I mean, when we heard dentistry was going to be devolved locally, I, for one, was very anxious about this because the provision of dental service has been a very difficult nut to crack of NHS dental services. But it just goes to show what, if you've got an imaginative team and they are licensed to get on and do things, just what an amazing difference can be made, because 21,000 appointments is not a small number of appointments, and in the care homes it's a dramatic transformation as well, not just benefiting the individuals but actually the general health of those individuals beyond just the dentistry. So for me, this says what we can get done if we're licensed to get on with it, and can do what we use our imaginations and crack on. So congratulations to everybody involved, because I really thought we were just going to be there actually to be whipped for not delivering because everyone had found it so hard. But this imagination has changed the landscape there. So thank you for that. That's Pam and the team, I guess. But you'll pass that on, won't you? Thank you. So that having been said, any other questions or comments about this quality report? Peter.
Yeah, thank you. I just wondered about the risk in 2.8, so about the adults with, children with learning disabilities and risk of admission. Just wondered if there's any update on kind of progress on that. So there was a summit in January and kind of timescales around the action planning.
Yeah, thank you. So the summit held in January was focused more on the adults position, and there is a separate summit which is now being considered around babies, children and young people. But I know I don't want to steal Becky's thunder, obviously now as the SRO for the LDA programme for health, but there are ongoing actions underway, not least review of Section 75 arrangements, and obviously considering that real focus on, particularly in the children and young people space, I think the prevention arena and that really holistic support offer for those children and young people, which is vital. But yes, colleagues will be and partners will be invited to the CYP Focus Summit later this year.
That sounded like a bit of an invitation, Becky, if you wanted to say something.
It was an invitation, but Giles summarised very well, so thank you.
Great. Jeffrey and then Neha.
Just a quick one. Thank you for that, and really good to see all the different work going on. I think my question really is around health inequalities in some of these initiatives. So if you take the hypertension case finding, for example, to what extent are we overlaying health inequalities to try and do the case finding and the referrals and all of that stuff? Just the thinking around that, whether it's a socio-economic or whatever it is. Yeah, thanks.
So again, within our health inequalities programme, the cardiovascular disease is one of those key priorities, and it's key to the development of that new model of care. So as we develop our MTP and we move forward, we need to make sure we've got a quality impact assessment in everything we do that really starts to, not just starts, but captures exactly the point you're trying to make, Jeffrey, and allows us to be able to review that collectively as a system to be able to say, actually, where do we need to do and what do we need to do differently?
And Jeffrey, if I may add, there is new guidance in relation to quality impact assessments, which actually absolutely has a focus on this. The guidance is in draft. We're reviewing that at the current time as an ICB to ensure that at the beginning of any process, both equality and quality impact assessments are undertaken, and they are iterative documents. So it really will focus on those areas.
I mean, that might be, because it's a priority, it might be an interesting area for us to have a wee paper on at some convenient point too, so that we can think about those sorts of questions, Jeffrey, yeah?
Yeah, more than happy to. And there was obviously the CQC framework that was also published not long ago, and we are going to be using that to develop our recommendations going forward. So happy to bring that back as a paper.
Great, thank you. Neha?
Thank you, Mike. I think it was just to add to what you mentioned about the dentistry deep dive and actually the program. No, we covered, and I think predominantly for the patients in the in the care homes and so on. But actually, what it brought out also was for the staff. The staff satisfaction went through the roof. Quite often, that's something, and if that was just amazing. It was well rounded, and I think there's a second. We're hoping it could be extended, but I think that was something notable there. That it was about the health inequalities aspect as well, Jeffrey, in that, because quite often that kind of demographic is completely lost, and it worsens over time. So I think that was one thing very notable. And the slides don't actually bring out what came out in the deep dive story. And I would recommend, if we do have a session once, that should come here for everybody to appreciate. So I just wanted to add that, Pam, and well done again.
Thank you. Alex?
If I may just add to champion my internal Barry in this moment, we are having quite exciting work carried out under the Athena platform that we're using to, again, help us with the case findings. So there is a specific tool that Barry and the team are developing that will help our practitioners, our growing integrated neighbourhood teams, to be able to really identify both CVD and many other conditions. So that is an exciting development in that space.
Thank you. Yes, Lucy?
Thank you. It's on dentistry again. The high level results that have been reported are really impressive, and certainly as a previous DPH, it's been an area of concern for some time. I guess the challenge is, I can see that some pilots are funded till the end of this month, others till 2028. So how and when will the ICB take a view on the efficacy of the different pilots and look at funding in relation to making them business as usual? And I recognise all that we've talked about the challenging financial backdrop to that question as well.
Who's going to take that? That is a difficult question.
Thank you, Lucy. I think it's important to note that we are looking through all of our funding arrangements. The care home pilot has been approved for ongoing work because of its outcomes. We have to look at the broad range of all of our dentistry offer and make it sure that we've got equity across other pathways as well. So we are reviewing that through our financial work, but I can assure you that care home work will continue.
And I should have said, this isn't the end of the story with dentistry, because we know the problem is much bigger than this. But it's the old joke about, how do you eat an elephant a mouthful at a time? That we've got to make step by step on this to make progress, which is encouraging. Okay, so I think we've noted the quality report, which is what we're asked to do. We come now to finance and performance. We'll begin with finance, Jim.
Thank you, Chair. And just to note, Sam Goldberg, who is our Executive Director for Planning and Performance, is not with us today, but I will take some points on the performance report. And if we have any specific questions, there may be other executives around the room that wish to contribute. If not, we can take those questions back to Sam.
Yeah, or Giles can answer.
Or Giles can answer. Indeed, so just to deal with finance first, though, the key thing I'd like to highlight in the report this month, which is the month 10 position, is you will see the change to the forecast outturn position for the ICB and the system as a whole. So at month 10, we have moved our forecast outturn position, which was previously reported as break-even with the inclusion of the 96 million deficit cash. That has now moved to 32.5 million deficit position for the end of this year. What that means is that we are increasing the deficit that we were anticipating to have at the end of this year, because we have reviewed the position. Now, the board will be aware that when we entered into the investigation and intervention programme back at month 4, ourselves as a system were on trajectory to hit a deficit somewhere near 180 million. Eye-watering figures, unacceptable figures. We have managed to pull that back. So if you include the deficit cash for just this second, there's 128 million deficit that could have been against a much adverse figure to that. That has been a tremendous effort across all 3 organisations in response to the I&I, particularly in our Mid and South Essex Foundation Trust, which had the lion's share of that deficit position. So whilst it is not where we want to be, and at month 10 we have moved our forecast outturn out, I can absolutely assure the board that there is still 100% commitment to driving even that position down before we get to the end of month 12. I'm conscious that's only a couple of weeks away. Our month 11 figures are still working through governance, but they are starting to show an improvement. And indeed, we have seen an improvement in our run rate continuously now for the last 4 to 5 months. So big thanks to everybody for all of the efforts in this space. It has been, it's been really quite remarkable. So we continue in that vein. We can continue to plan to improve on that deficit position for the end of this year. What I would just draw out as in the construct of that is that the ICB is maintaining its break-even position for this financial year. So we intend to continue the break-even position as we had set out to do. Our MSEFT will be moving their position at the moment, a month 10, that is around 19 million, but the ambition is that will close again before we get to month 12. And EPA, our mental health trust, will be moving its position out by another 13.5 million too. There are no new pressures in there, Chair and Board. It's consistent with what we've reported and the conversations we've had around this table with respect to the struggle we've had to release efficiencies, the challenge we have around our temporary workforce in our bank and our agency, which we have seen significant improvements in, which has been driving the run rate improvements as well, and then our own ICB challenges around the continuing healthcare market, etc. So there are no new themes to alert the board to at month 10. However, we have moved that year-to-date month-end position, forecast outturn position out. I would just draw the board's attention to the fact that we have an improving run rate, and year-to-date our position is an improvement on last month's.
Thank you. I can't invite Paul to speak because he's not with us, because he's attending this meeting in the NHS England called in London at the last minute. But Matthew, you're with us. I don't know if there's anything you wanted to update us on in and around the financial performance.
No, thank you, Chair. I think obviously as Jen's reported, significant progress has been made this year so far. Has been clearly at the cost of waiting times reduction, and also our staff survey results are not pleasant reading. So I think it's important just to note that, particularly in the acute sector, consequences of significant change that have affected our staff has come at a cost.
And there's more to come by the sounds of it. Yeah. Yes, Joe?
Thanks, Chair. Jen, just wanted to clarify, we've found the inflection point now with MSEFT, and we've got a trend of improvement, which we welcome. The ICB is in balance. You know, we've recovered our position into month 10. If you take the exceptional items out of EPUT's performance, is their run rate holding, or are we concerned that it's moving in the wrong direction? But I know there's some exceptional items. I just wanted to clarify on that point. Thank you.
Thanks, Joe. I think from the perspective of EPUT and in Paul's absence, the cost pressures that they're experiencing are all solely in their mental health inpatients. So the entirety of the organisation and other divisions are actually performing within their envelopes, and actually some of them under those envelopes in order to support that mental health inpatient pressure. That, of course, is connected to a large degree to the level of scrutiny in the Lampard inquiry that they're currently managing. I think it's very difficult to understand, given that we're actually seeing a national pressure in that place as well, how much of it is actually being compounded by Lampard and how much would be the challenges that actually a lot of our mental health trusts up and down the country are facing, particularly in the mental health inpatient space. I think over coming months there will be a need as we go through the planning round to understand that a little bit more, because as you say, we have the inflection point with MSCFT, which was a few months ago, and we need to understand what that looks like for EPUT and how we can support them as a system, given their immense amount of pressure they're under in that space at the moment.
Yeah, thanks, Jen. I just wondered if it was causing need to reflect on the mental health minimum investment standards, and because there are certainly trusts I'm hearing that are reinvesting in beds because pressures are just so sustained.
Yeah, so it's definitely something we're considering in our planning round, Joe. So at the moment, we've got our mental health standard is met, and we have used the flexibilities that we've been able to support EPUT in that space, and we will look at it for planning into next year. So there is a mental health investment standard that has survived the review of priorities and continues to be effectively ring-fenced into the new financial year. We will look at the priorities that we're expecting from that, and then we'll understand how best we can utilise any remaining funds within that, in the same way that we have with the supporting the time to care arrangements with the trust. We'll continue to support EPUT in that space.
I mean, I think all that's true, but I've certainly seen a benchmarking report, which is if I were in EPUT and Paul were here, I would be thinking about what that was telling me in terms of the staffing and other base that I had to support the patients, which I think shows there is scope for them to be in a better financial health than they currently are. That would be my view from just reading that benchmarking. I'm not an expert in mental health, but that study shows you should be asking, I believe, some questions.
Thank you, Chair.
George?
Yeah, thanks, Chair. Jen, just on the capital, I see that we're going to be underspent on the original budget, and I guess when you're walking around, you're always hearing that people are wanting to spend more and there's not enough capital around. So I'm a bit surprised that we're forecasting that we're going to come in well under.
So part of the forecast underspend is due to the reprofiling of a couple of projects. So obviously we manage with an annual capital allocation, but what we're trying to manage is multi-year plans across that. So we've had a reprofiling of our UEPR case, so our Unified Electronic Patient Record, and that's been in conjunction with the national team that's been reprofiled. And we've also got a slight reprofiling on our 23-hour day surgery unit as well. What that means is that some of those projects will take up some of the space in next year's capital programme. So the team are looking at what they could potentially bring forward. So everything is prioritised within our trusts, within EPUT, within MSCFT, and even within ourselves, so that we can make best use of that capital as it comes along. The overall programme is enormously oversubscribed, as you know, but there's an art of the possible in terms of timing with capital. But the teams are still working on what they can do to make sure that we don't lose any available funding because of that reprofiling.
Yeah, that's the crucial point you're making.
Yeah.
Are we losing money? No, you're saying.
The aim would be that we will minimise any impact that we have, but I'll be able to confirm that as we move through the.
There are many people around the table will volunteer to spend any money that you can find us for our pet projects.
Are there many?
There are.
Oh, there are. And of course, George, it always comes with the challenge of the revenue consequences, doesn't it? So that is the challenge we face.
Okay, so shall we move on to performance?
So, Chair, I'll take the performance report as read, just to draw out, and I think Tom's noted it in his opening Chief Executive's report as well, we recognise that our figures are not where we need them to be in the performance space, and obviously a lot of energy and effort is also focused into next year and what that looks like for us in terms of delivering the performance within the financial envelope. I think it's clear to say that our trust are still working incredibly closely with national colleagues and the Cancer Alliance on understanding where improvements can be made, the trajectories, and pathway analyzer tools, etc., which are really helping to support those changes. I think George's recommendation that we have a succinct paper that kind of covers some of those actions in more detail will help satisfy some of the need for some more assurance in this space that every effort is being placed into that space. RTT as well we're still in tier 1 for RTT, and we now have support from the intensive support team at National, who are helping us with some modelling, which is incredibly difficult in the RTT space, given the waiting list and the backlog and how we look to going forward in the new financial year. So lots of energy and lots of space across performance as usual, trying to think if there's anything else that Sam's probably going to kick me for not covering, but if there are areas that other execs are particularly involved in that wish to comment, then I will give way to them.
Shahina?
Thank you. Just a plea, Jen. In terms of the table for RTT position, it would be quite important to actually look at the percentage of people waiting as well, because what you've got is numbers, and then those numbers look so big in some cases, but then the number of people in that specialty are so much bigger as well.
Yeah.
So that will give a better overview. Thanks.
Yeah. Indeed, Gina, I think there is still some work to do on the report, isn't there, particularly getting it into a more of an SPC space. And we will look to make sure that that's in a more user-friendly, accessible format for the new financial year.
Yeah. Thank you. Some of the issues behind in the page here are things that we are thinking about in the work, which has kind of not been formally yet before the board, to do with our medium-term plan. Somebody mentioned that, Becky mentioned it earlier. This is where we need to work together as a system to try and move some of these agenda items on. Matthew, again, I don't know if there's anything you want to say about that, but we're kind of determined, aren't we, together to start asking ourselves difficult questions to try and improve these outcomes, and it will involve asking ourselves difficult questions and implementing, no doubt, difficult answers.
Yeah, I think just very briefly, Chair, I think that's a good statement. Clearly, the conversations we've had around this table previously about pathways of care, referral pathways, treatment pathways, how we make sure that across those pathways we're utilising best practice is clearly going to be the territory that we're going to need to make more progress on. I think from within the Acute Trust perspective, there's no lack of commitment. But some of these issues are long-standing, and they have been supported by non-recurrent funds. And in a financially constrained environment, we've obviously got to change the nature of how we fund and resource core capacity. So in the planning for next year, that's obviously going to feature quite strongly for us as a trust and obviously as a system as well. So we make best use of the available acute service resource, which is, I think, number 2 or number 3 of the 6 priorities in the medium-term plan. So it all links together, but this isn't a week next Tuesday fixed scenario. These are things that are going to take a bit of time. We've had our board meeting in private today at the trust, and spent a long time on the trade-off between how far we can go next year in relation to reducing waiting times and the financial constraints that we're under. So it's a very live discussion, Chair, to reassure the board.
Yeah, thank you. And I mean, I think it's also about we've been given priorities, and clearly we need to address those, and we need to keep the number of priorities. It's not a priority if there's a list of 23 of them, is it? We've got to really have got to focus down if we're serious about getting some things done severally and together, no matter what pressure we might find from wherever. I think is going to be the answer. Any other questions on this or comments on this performance report? If not, we note it and we come to Primary Care and Alliance report. And that's a number of contributors. Pam, you're at the top of the list, so you get the opportunity to go first.
Yeah, my colleagues have voted for me to do that, but I will invite them
We'll
to
chip in.
contribute, as I will ask for comment from Anna as our primary care representative, as well as, Mr. Chairman, you might wish to feedback from the innovation you saw yesterday. So I will take this paper as read and draw the board's attention to the case study that we have included that brings the work of alliances and primary care to life, and a simple human response to someone that was discharged from hospital that could have easily been a readmission, with the support of our partner work from welfare calls, identification of someone and following up from the GP with the social prescriber to ensure that that individual was supported effectively by voluntary sector and reintroduced to their community. I think it looks and feels like a very low level intervention, but actually has significant impact on the way that our system works. And these are offers that are more frequently being offered now through our integrated neighbourhood team response. So most notably, since we last met, the government has issued and agreed an offer for general practice with the BMA, which has caused the pausing of the collective action that we talked about in this board so regularly around the primary care medical offer. And so we note significant change in the GP contract for 25-26. This isn't a substantial contract deal. That is to be negotiated in the term of the current government. But this is the deal that's on the table for 25-26. So a change of QOF, so quality of outcomes framework that general practice have used. I would like to say that whilst I know that was negotiated a long time ago, I would say it was probably one of the most substantial interventions within primary care for improving quality. And you speak to any general practitioner, and I hope Anna will back me up on this one, actually it changed the way that services were offered to individuals. But the time is now for a relook at what is important, and the model of general practice that we now see has changed so significantly with the advent of digital offers and the introduction of the additional roles reimbursement scheme, which is so varied in profession that we can now access in primary care. So we talked a lot about dentistry through this meeting today, so I won't go over that again, but we know the requirements of our dental offer. We're over performing in that space currently as a system which is unique. But equally, we have to look at the sustainability of all those offers and the funding arrangements, recognising the ring fencing around dentistry, but also the challenges that we see in head and neck cancer services, and what can we do to unlock some of those blockages for our residents within our dental offer. Also, I know we've got Owen with us in the gallery, and we have received a very warming evaluation of Pharmacy First that has recognised the ease of access for the public and the value that they put on that offer, and that is equally going very well amongst our pharmacy offers across the patch. I will turn to my colleagues for the Alliance update, but I think to recognise there has been a relentless focus on integrated neighbourhood team development since the planning guidance has come out, which recognises that neighbourhood level of working, and the programme approach to that fits inside the medium-term financial plan, and switching that offer much more closely to a proactive model for frailty and end-of-life services to reduce the demand on both GP, voluntary sector and secondary care, to enable us to have a proactive care model within our system that will improve patient experience as well. So I'll ask my...
So let's just pause you there.
Yeah.
So Anna, do you want to add, I mean, particularly around the sort of, changing QOF and things like that. And then Matt, maybe something about frailty, because that's an area where we're offering leadership to the rest of the east of England, and it would be worth having that on record. Anna?
Thank you, Chair. So the new contract settlement is welcome, but it's worth pointing out that that 7.2% does include the extra provision for the national insurance contributions that are going to make a significant difference to the budgets within practices. So there's no exemption for GP practices. We will be paying the higher national insurance contributions, so that has to be taken into account. And the QOF, yes, it's welcome, but one of the areas of concern is that the money is being put into cardiovascular disease and also childhood vaccination rates. Both of those targets are more difficult to attain in practices with high deprivation levels. So the concern here is, could this actually be worsening health inequalities in Mid and South Essex, because the very way that practices will be remunerated means that those practices in more affluent areas who are more able to hit the CVD and childhood vaccination targets are going to be doing better with this arrangement than previously. So we really need to keep a close eye on health inequalities and look at trying to mitigate that when it comes out in the wash. Thank you.
I mean, is that something unconscious when we were going through COVID? I mean, we took the vaccinations to the people because the people weren't coming to the vaccinations, didn't we? I mean, is there something we can do in that regard?
Yeah, I mean, it's the reason they've done it this way is to drive up.
I understand, but if they're not going to walk into the surgery, could the surgery walk into them? If you see what I mean?
We as an ICB will need to do a lot to support those practices with dealing with challenging circumstances where they will need more support to reach those unserved populations. Yeah.
Thank you. And in and around frailty, Matt, just both for ourselves and in terms of what we're doing more generally?
Yeah, frailty care, particularly a focus on recognising individuals living with frailty, which is a syndrome, and that can be measured and can be documented. And there's clear evidence base of what to do there as well. We are a system leader there, our Ageing Well stewards, so our clinicians with an expertise in this area have developed an electronic tool which is award-winning, and are leading the way in essentially utilising this at scale using something called a population health approach. So finding individuals living with frailty in our community, but rather than waiting for them to come to hospital in extremis, targeting them early in the pathway, and then intervening with evidence-based intervention, which is clearly recognised in the literature. What we are aiming to do as a clear priority in our medium-term plan, driven through our integrated neighbourhood teams, is to focus on recognition, diagnosis and intervention for frailty and those in their last years of life. We think from a health economic point of view, it has the best benefit for improving care of our population, but also stopping unnecessary admissions to hospital, freeing up capacity and support for primary care as well. So it's award-winning. We've done it in local areas in South East Essex, which has improved outcomes for our population. And our clinicians are driving the way forward at both a regional and a national level. And we're in discussion with British Geriatric Society, for example, as areas of good practice. So that will be an absolute key area of delivery in the next year, driven through our alliances. But I think it is a game changer, developed in-house, and we're really proud of it as well. And I'm happy to bore anyone with the details of it, should you like to come and find me or our teams.
And should they be capable of remembering? George.
Excuse me. Always impressed with the level of detail our alliances get into in terms of the local economy. And I guess linked to that was the 7 million GP appointments that were delivered last year. And I guess at some point we need to start tracking combined activity, because, you know, all the direction is left shift. So if we can see A&E attendances, GP appointments, other linked together, so we can then start monitoring, tracking how we're doing against it, because everything should start to indicate we should start be moving people out of A&E. But I know from A&E, it's not happening yet.
Well, so it's just a shame you couldn't be with us at the ICB. yesterday because we had a case study. Now, this would just be a test to see if I was listening, but would you, Pam, like to describe it, since the two GPs who spoke so eloquently with data about how their very clever interventions by looking at the patients who were their most frequent customers, if I can put it that way, and working out why it is they came to see the GPs. And these two inspirational GPs had used the IT system and created a package of care which got those individuals the care they really needed, where otherwise they might have, if I continue the customer analogy, of shopped in A&E, they got the care they needed more quickly and more beneficially by going elsewhere. And there was hard data that these individuals who never probably would have got what they wanted from ED, wasn't available, were, more satisfied as a result of those interventions. And it partly hung on the fact of these new additional roles that we've been able to support in Gs. How have I done with that active listening? Was that all right?
Yeah, I mean, I think what we saw yesterday was a business approach to system re-engineering and a recognition by the partners that they can no longer continue to see people, and a very honest response that says, as a GP, I can't help these people. It's a psychosocial problem. It's a housing problem. It's a this, and actually I'm the last person that can help. A recognition that they relate to the fuller stock take report and have seen their PCN in a wider system, but taken a very, very, sort of data-focused patient segmentation approach to what's the problem we're trying to solve and how can we solve it. And their leadership in that space has demonstrated that those frequent attenders that are going to Matthew's A&E more than 10 times a year. So we took that data set and we said, let's not use a different project to do high intensity users. Let's do it through the integrated enabled team. And let's combine the data with the high frequency users in A&E, in the practice. Pulled those data sets together and then had a very structured approach to intervention. And the single biggest thing that they did was spend time and had a conversation with the individual, used the care coordinators, which are not high band analysts. They're personable people connected to communities. And the outcome was 50% reduction for A&E and over 30% reduction to the practice initially. And they've done the longitudinal study that then has been sustained, and that it's dropped to even lower than 30% in general practice. So it's freeing up capacity, and it's giving the individual a sustainable solution. What it does then drive is, can the voluntary sector continue to support that if we go at scale? And that's a question we need to ask ourselves. But actually connecting those data sets on a person, rotating around the system, not getting the answer, how much does that cost all of our organisations? It costs a significant amount. And where we've got practices that are working directly with social care, triaging in the morning, they're saying things like, don't start a safeguard with that one, we already know them. Actually, they're already known to social care, they've got an allocated case manager, let's talk to them first. So very practical solutions of practical integration, which reduce the duplication. So, yeah, you listened very well. I just had to share that bit around.
And the only other thing I remember, and I won't get the second digit right, the second figure, but curiously, the age range of this group was 15 to 45. That was the curious thing. So it's not what you might think.
Yeah.
Anyway, I have a queue, which is Nihat and then Shaheen.
Yeah, I think just to add to what Pam is saying, unbeknown to us about this excellent presentation, which I wish had attended, at our quality committee, if you recall, Giles and Sharina, we did discuss, because Di was there to tell us about the Section 31 and acute and what the issues, and one of the issues was this, repeat visits, not just by the patient to A&E where there was issues about managing the space and managing, actually clinical presence to triage them quickly, but also then associate with every one of that patient, their family members and so on, attending A&E and their work. And this was, we actually said, we need to do something like this, a data, analysis of the frequent flyers, as I like taking a different analogy, linking it back to exactly what you've said, this saves this, and also perhaps linking it to the pharmacy first offer as well, and see then what does it add to that and bring the numbers down lower. So this is exactly what we were discussing for a real life problem in our acute settings, which should be used. I mean, this data should go somewhere and used further too.
Thank you. Shahina.
Yes, and for me, the important thing was that all of that was achieved with no extra injection of money. Whilst we're on data, there is a graph that talked about consultations in primary care within South Essex, and there's a huge spike in October 24 to over 700,000, and then December 24 going down again. And I would have thought it'd be the other way around because winter is November, December. So is this something that was unique, and how do we mitigate that happening again?
It's a very simple answer. It's open days in Christmas because there's bank holidays. So Monday to Friday work and vaccination. So that peak is vaccination in primary care. So it's quite, those of us that see it regularly, it's a very common peak and trough. But
I can see it happens the previous October.
yes, we invite so many people in for their vaccinations, and we do it, like a machine in community centres and all sorts of things. And that gives you that high number. It's not consultations as such, but of course they have to be recorded as consultations.
Here I am, 2 JAGs every October or whenever it is. Yeah.
2 jabs.
2 JAGs. Called JAGs in Scotland. Two JAGs, hence the joke with whatever it was called. John, yeah, okay, two JAGs. So onto the alliances where I interrupted you, pause you.
No, that's okay. I think just to say, because we haven't got our mid-Essex colleagues here, they've been working with their Section 106 monies and have done a very good job of releasing some smaller projects to reinvest into primary care estate. It continues to be a challenge for us all, but I'll let my colleagues talk about that. And in Basildon, we've been really focusing on the INT delivery, starting in the homeland of primary care. So over to
I will just go back to the 2 GPs, because they did say, if you weren't there, the fuller stocktake report came out and they hadn't read it because it was an NHS document and they hadn't read it. And then I think basically Pam motivated them to read this, all 35 pages of the document, which is briefed by NHS standards. And then they sort of started to see the light. So well done, Pam, on that one. So I don't know, Becky, Alex.
I mean, I don't mind starting, just in the sense of whilst we're still on primary care, I think it's only right to just mention that there's a huge amount of activity in primary care across MSE, but particularly in South East, particularly around some reconfigurations of our primary care networks. And like Pam said, in mid-Essex, what we are really trying to do, particularly in one area and learn from that first, so starting with Rochford, is how we can leverage our Section 106 monies to improve primary care estate. So that's quite a significant piece of activity. Equally, along the health inequalities route, we continue to discharge the health inequalities funding through our trusted partner, and we have multiple schemes which we have done that through 24-25. And the most important part of that is then learning from it. I think it's only right, and we picked this up, Mike, in the Integrated Care Partnership yesterday, what has been a strong feeling throughout South East Essex Alliance is the ongoing vulnerability of our voluntary community sector, and how we can take collective ownership, oversight of actually how do we better understand that vulnerability as a system and work with that sector. And I think the developing assembly is hopefully going to give us also that kind of leverage to do so. And then a couple of just other areas I would mention, we are continuing to do quite a significant piece of work around our Southend Enhanced Discharge Service that Mark might want to talk to. And we are and have agreed a model going into 25-26, which has been significant in the discharge to assess with Southend Hospital. And again, lastly, just to touch on, I think there is more work, and Pam knows this, that we need to do with primary care and our acute sites to make sure that actually when we are starting to think left shift, we have that interface and those processes right, working efficiently and together. And I think in challenging times, there's a danger where we can become siloed, and we need to just protect against that. Alex, over to you.
Well, should we just, that was a cue for Mark, wasn't it? So let's pause, let's pause Alex and give Mark his cue.
Thank you. I think Becky's explained quite a lot of it quite well. I suppose just to say the work that's been done on SEDS between the ICB, the trust partners and the authority has been really positive. I think it's probably a really good example of how that kind of integrated approach is delivering much more efficiency and better outcomes at the same time. So I think Becky, it's fair to say, has delivered in-year efficiency this year, but certainly going forward next year, getting the right organisation to do the commissioning at the right price with the right expertise, and then getting other organisations to lead on what they're really good at has been very positive and kind of brought pretty much all 3-4 partners together in terms of a better model of delivery. And the outcomes are improved. We know our delayed discharges are incredibly low as an ICB. They're the lowest around. The impact of social care delays is lowest. It's in the top 10% of the country. So I think the model's a good one and just a really good example of working together.
Thank you. And now it really is your turn, Alex.
That's right, last but not least. I think there's a couple of things that obviously go across all the alliances, and we touched on the estates in particular. In Thurrock, we're really focusing on sustainability. So as much as we're trying to access every one of 6 possible and available to us, we're also working with the principle that, as my architect colleagues say, the most sustainable building is the one that's already there. And we are very much looking around retrofitting and upgrading every single void space possible. Again, in conversations with local authority and other partners. We are collectively working jointly around improving our rates of dementia diagnosis, as Matt mentioned, around frailty. So in order for us to identify frail patients, it's about improving the numbers on the end-of-life registers and using the FRIDA tool to find them. Everything that Pam described in terms of the approaches through which we deliver in alliances is a definition of personalised care. In Thurrock, we call that human learning systems, but principle is of starting with conversation with a patient, with individual about what matters to you, supporting that with shared care record, digital solutions, social prescribing, and also integrated budget. So again, there's a lot of work happening in that space. The ongoing dental program in Thurrock around early years oral health is still championing the bits at every opportunity of visiting local schools, and we've managed to deliver thousands upon thousands of toothbrushing kits, and you will be possibly surprised that 1 in 4 children in some of the most deprived areas do not even own a toothbrush still in our system. We've also
1 in 4.
Yes.
I knew there was a national figure, which I might have learned from Lucy, about 1 in 10 in poor communities, but 1 in 4.
1 in 4. Thurrock has one of the worst levels of dental tooth decay in children. So this is exactly why we've targeted this as a patch, and we're now spreading that work across the system. We've also commissioned Healthwatch in our voluntary sector to help us carry out a consultation to the 10-year plan, and that report has recently been delivered. So again, this is something that Rob and I jointly commissioned, again, to support our CVSs, but also to really work hand in glove across the alliance to provide the government with the local feedback from Thurrock. So I think that's us, unless Rob wants to make any comments. Thank you.
No, and then I'll put the microphone on.
Yes.
No, nothing, but just to clarify, I think just for the figures, it's 1 in 4 children don't have access to a toothbrush, but there is evidence that 1 in 10% of households don't have a toothbrush. So that's the distinction on the, on the toothbrush. And just to say, as far as the NHS plan consultation, I've requested the email that I gather DHSC has passed to Health Watch in Thurrock, expressing their appreciation for this. They were very positive about the response that was received from Thurrock. And so there's a second stage of that consultation, which I know the government has announced and follow up. So we're now following up on that at the moment.
Thank you. Shahina?
Thanks, Alex. With my other hat on as university professor, I've been looking at some data on vision impairment, and in Thurrock, we've got the highest number of people who are blind. And I was just wondering what priorities you actually give to what needs to be done, and how is that based? Because I'd really like that sorted out.
And we did have initial conversations about it, didn't we? So we've had a conversation with the team about this, and actually we feel there might be some opportunities of working with the family hubs in that space, and also utilizing some of the digital solutions that you suggested. So team is very much up for exploring those opportunities, all if our very tight funding allows us to.
So I mean, in terms of prevention, it would be great.
Yeah, you should have a conversation, because Shahina also has some interesting numbers which she will report at one of our future meetings about the difference we're making in the care of people's eyes along the lines of dentistry. Almost encouraging.
I am well aware, and I still have that eyes clinics that she set up in Cambridge. So absolutely, I'm leaning into the right side. Thank you.
Great, Joe.
Thank you, Chair. Just a small point. I noticed in the report about an INT network team data dashboard being developed or trialled. I'd be really interested to just get an early sight of that. I'd be just interested to see how that's developed. Yeah.
Yeah, more than happy to, Joe. We can send it
Thanks,
over
Becky.
to you, and then when actually we have a kind of prototype, we can bring it to the right forum, so we can agree that offline.
Lovely, thanks.
Thank you. Any further questions on this report? I mean, you know, listening to what's going on, everyone around this table is about leading this integrated care board, and our job is to lead through whatever circumstances befall us, isn't it? And I agree that we must do that, notwithstanding the difficulties of governments doing what governments do, and we must not lose our core principles, which is to encourage people to innovate, to give people their head to get on with stuff, the leadership conference yesterday, and so on, to work as partners across local authority boundaries between acute, community, mental health, and so on. We must cling on to all of that value so that we can do the best for our patients. And there's evidence there that we are making progress. There is still plenty to do, and we've started to call that out more clearly so that we know the task ahead. I believe we're being honest and straightforward with ourselves, but there's so much encouraging data that if we allow innovation to take place, find ways of doing it, we can move on, do national leading, award-winning things. I'm sure the dentistry work is actually probably nationally leading as well, and other stuff too. So we've just got to cling on to those values as leaders and as a community, no matter what, so to speak, befalls us, because governments are governments, and I hope that we can achieve that. And that's the challenge upon us, I think, as a leadership group. We've now got general governance papers there. I think all to note, unless any committee member has sort of alerted me to the fact they wanted to bring out something, I usually just take these as a matter of record. So if that is the case, I think then that's the conclusion of this part of the meeting. I thank members of the public for their attendance, both here and online. There'll now just be a small pause while we regroup. We say thank you very much, and we go to part 2 of the meeting, which is matters which are commercial, and we'll go on to those in just 5 minutes. Thank you very much indeed.
Yeah.